For those joining, we're going to give it about a minute or two, let everyone hop on, and then we'll start our webinar. Okay, I see the numbers have finally studied. We'll, oh, I'm so sorry. What happened here? I'm trying to get out of my screen here. There we go. There we go. Well, good afternoon or evening, everyone. I want to thank everyone for joining us today in our continuation of our safety webinar series. My name is Lily Calderon, Director of Health and Safety Programs for the International Union. I'm joined today by Dave Wysocki, IMTEF National Safety Director. As you may or may not know, May is Mental Health Awareness Month. The construction industry is very physically demanding, and it has its own set of hazards like falls, electrocution, struck by, caught in between, silica, and many more. We address these hazards by providing hazard awareness training, providing resources. Today, we will talk about mental health in our industry. We are committed to the safety and well-being of our members. We would like to provide you with the tools to help members in need. The CDC states that the rate of suicide among male construction workers is 4 times higher than the national average. And to help us in our discussion today, we have a special guest. Alex Jacobi is a seasoned licensed mental professional and director of the Bricklayers Member Assistance Program. Alex has been with the International for many years and specializes in helping members of the BAC manage job-related and personal life challenges, as well as navigate next steps when further help or treatment is needed. Alex has experience working with a wide variety of conditions, and her professional background includes working at Johns Hopkins Center for Addictions, as well as in community outpatient mental health and behavioral health managed care. Alex has a strong understanding of the labor movement, expert knowledge of the kinds of challenges tradesmen and women face, and a true passion for BAC member advocacy and support. In addition to her commitment to the well-being of workers on an individual level, she is closely involved with and leads numerous efforts to improve construction worker mental health outcomes more broadly, and is deeply encouraged to see industry stakeholders at all levels coming together to look out for brothers and sisters in need. I would also like to relay, so welcome, Alex. I would also like to relay a short message from IU's Secretary Treasurer, Jerry Sullivan. He hopes that everyone enjoys today's webinar and thanks everyone for their commitment to safety and health. And now, before we begin today's webinar, I would like to go over some housekeeping items. This webinar is being recorded and will be available for viewing on our website, bacweb.org/safety, as well as all past webinars. We will have a question and answer session at the conclusion of our presentation. Please use the Q&A box to submit questions during the presentation and or at the end. We will get to them in the Q&A session. And as always, please feel free to submit any recommendations for future webinars. Thank you all. And with that, we will begin as soon as I can pull up the PowerPoint. Let me share my screen. Okay, take it away, Alex.
All right. Hi, everyone. Thank you so much for coming and for having me tonight. I'm really happy to be here. I am going to actually turn off my video because when we were kind of testing things out earlier, we realized that it might, my audio might come in stronger or more clearly when the video is off. Really quickly, it looks like, for me, it looks like the PowerPoint is blurry. Does anybody else see that? Or is it just me?
It's good on my end.
What's going on with my internet? Okay, well, I'm just gonna have to, as long as it's good on your end, that's the most important part. Can you all hear me okay though? Or can
We
Yes.
can
Lily,
answer,
Dave?
but Dave, yes.
Okay, but you can. Okay, great. All right, well then I'll as long as everyone can see the slides, I'll work from my slides as well. And we can move to the next slide. So this is just a really quick overview. If you aren't familiar with our department, a really quick overview of what we do at MAP, how we can be a resource for both members and BAC leaders and partners. My understanding is that we might have a little bit of both on this call. So I'm going to really try and make sure I capture all folks and audiences and not be too kind of like prescriptive towards one particular audience as opposed to the other. I'm going to be as inclusive as possible. So for members, our kind of like primary role is our helpline, 1-833 MAP Talk. When you call our helpline, you are going to get connected to either myself or my colleague, Daniel, who is a licensed social worker. I'm a licensed mental health professional. And essentially, we're going to do a very informal kind of triage or assessment of what the situation is, what's going on, provide support as needed, whether it's just in that one call, ongoing calls. If you need to call me every single day for the entire year, you can do that. And then go from there if additional help or resources are needed. We're typically open. We're a small department. You know, we want to manage expectations. We don't have the infrastructure for like a big call center like the National Crisis and Suicide Lifeline. But as I'll talk about later in the presentation, we have our own kind of unique value that complements those other resources. We are always taking calls between 8 a.m. and 7 p.m. Eastern Standard Time, Monday through Friday. Frankly, though, my phone is always on. I'm always available to members. I cannot emphasize how passionate I am about this work, about this role. And so, you know, if I am awake, available, conscious, I will take your call. And then the other piece is this kind of like support role for BAC leaders and partners, education, consultation, collaboration, training, really anything we can do to help the people that are kind of like the stakeholders of this industry, the gatekeepers of our workers in this industry, improve mental health outcomes for members more broadly. That's what I'm here to do, to really, really support those efforts. So I will talk more about MAP later in the presentation. That's kind of just a brief introduction to our role at the International. Lily, would you mind next slide? Thank you. Okay. So before we go any further in the presentation, I did want to take a moment of silence in recognition of last week's Worker Memorial Day, the upcoming Construction Safety Week, and of course, as Lily mentioned, Mental Health Awareness Month, and the fact that suicide and overdose fatalities are leading causes of death in the US and Canada. I think it's really important to take a moment. Everyone on this call I know has been impacted by these losses in some form or another, and to take a moment and honor our brothers and sisters who we have lost. Thanks, Lily. Could you go to the next slide? Okay. So before I kind of really further dive into content, I am wanting to do, in recognition or observance of Mental Health Awareness Month, I thought it would be nice to do a little bit of a status check-in, kind of just encourage folks to do a little bit of turning inwards and seeing where you're at. I know in the union world, we are big on thinking about others, taking care of our brothers and sisters. We aren't necessarily as good as focusing on or taking care of ourselves. So I want to just pause and take a moment to give everyone the opportunity to really just check in and see how we're doing. So just obviously silently or to yourselves, I'll read through these questions one-on-one, and I'm just going to ask you to respond to them to yourself, for yourself, with never, rarely, sometimes, often, or always. So in the last week, I felt happy, never, rarely, sometimes, often, or always. In the last week, I've been able to cope with all the problems that have arisen, never, rarely, sometimes, often, or always. In the last week, I felt good about myself, never, rarely, sometimes, often, or always. In the last week, I've felt relaxed, never, rarely, sometimes, often, or always. In the last week, I've been sleeping well, never, rarely, sometimes, often, or always. In the last week, I've been satisfied with my relationships. Never, rarely, sometimes, often, or always. In the last week, I've had healthy habits, hygiene, diet, exercise, things of that nature. Never, rarely, sometimes, often, or always. In the last week, I felt physically well. Never, rarely, sometimes, often, or always. In the last week, I've been able to focus. Never, rarely, sometimes, often, or always. In the last week, I've made decisions I'm proud of. Never, rarely, sometimes, often, or always. And the last one, in the last week, I've been able to fulfill my obligations. Never, rarely, sometimes, often, or always. So after having gone through them, I kind of want you to just reflect upon yourself. If you answered mostly never, mostly rarely, mostly sometimes, mostly often, mostly always, and then kind of be questioning what that indicates to you about where you might be right now. If we're calling this, or we're looking at this like a status check, what would you say your status is? And that kind of insight and understanding or kind of reconciliation with where you might be right now as compared to where you were even prior to this exercise, or where you thought you were prior to this exercise, informs next steps, which is, I think, really the purpose of this conversation tonight, is to really encourage action, encourage next steps when they are indicated. Next slide, if you could, Lily. Okay. So I'm going to kind of just talk about mental health, generally speaking. I think there's a great misunderstanding about mental health, a kind of, for some individuals, kind of almost a resistance to even the concept of it. I know for a lot of folks in our industry, even just the language itself, the words mental health, they can imply maybe something that feels uncomfortable, maybe even indulgent. Talking about mental health feels like a luxury, and we don't have that kind of luxury. That's for somebody that isn't me, that sort of thing. So I'm kind of wanting to even just help people get comfortable with that terminology, with that language. So when we are talking about mental health, we're looking at an individual's psychological, emotional, and behavioral well-being. I think it's really important to note that that exists on a dual continuum, or a dual spectrum, meaning it's pretty complex, that simply the presence of a mental illness or a mental health disorder does not automatically equal poor mental health. In fact, there are a lot of people living with, in service of destigmatizing this topic, there are a lot of people living with mental illnesses and substance use disorders that are well controlled and well managed, and individuals have really strong coping mechanisms in place, and behavioral management, emotional management, psychological management, and therefore their mental health is pretty strong. It's pretty positive. It's pretty good. They're able to cope with life. Whereas there are other individuals who may not have a diagnosable mental health disorder or mental illness, who are not necessarily in good mental health at all, or are in poor mental health, that their state of well-being, or the quality of their state of well-being, is really actually kind of poor. They aren't necessarily able to cope with life. Their functioning is impaired. They don't necessarily adapt or learn, adapt to life's circumstances and learn and work well. So when we are talking about mental health more broadly, I think it's important to understand and recognize that there are a lot of reasons and contributing factors to why somebody might struggle in the way they struggle or not struggle. It's really not linear or one-dimensional. There are a lot of considerations when we're talking about how somebody is doing. So even just Mental Health Awareness Month more broadly, when we talk about it, we're covering a lot of bases here. We're looking at destigmatizing the existence of mental health conditions, mental illness. We're looking at being willing to address those issues, generally speaking. to make it as important a conversation as something like your physical health, psychological safety being as important as your physical safety. That's a really, really huge part of this. All right, could we go to the next slide? Okay. So, Lily kind of beat me to one of the stats here. These are just a few of some really what I think are concerning or alarming stats. If you've ever been in any sort of conversation, presentation with me before, some of this might be familiar. And if you are totally brand new to this conversation, you might be shocked. If you are working in the field, have worked on the field, maybe it won't surprise you as much. It will be, I'm sure there are a lot of people entering this conversation from different starting points, but it's important that we go through, that we set the stage, that we understand, we talk about this topic more frankly and transparently, because without doing that, we can't reverse these trends. We can't make progress. So I'm actually just going to read these one by one. Construction workers are 7 times more likely to die of an opioid overdose than workers in other professions. Of all professions, rates of death by suicide for construction workers are consistently amongst the highest. The suicide rate within the construction industry is 4 times higher than the national average and higher than all other construction-related deaths combined, such as accidental falls. Construction workers have nearly twice the rate of substance use disorders and alcohol use disorders as the national average. And actually, I don't have this stat on this slide, but another stat I came across recently was that 84% over 80% of construction workers have reported experiencing a moderate to severe mental health condition, which is substantial. Moderate to severe is pretty impactful in terms of your ability to function. So these are things we want to pay attention to. I'm just going to talk a little bit more for a second about this third bullet point here. That the suicide rate within the construction industry is 4 times higher than the national average and higher than all other construction-related deaths combined. I think it's important to note that that does not necessarily mean, we're not saying that all of these suicides or deaths by suicides occur on the work site. They have occurred on the work site, absolutely. But we know that there is a strong, I guess, overlap or crossover between our personal lives affect our work lives and our work lives affect our personal lives. And so if we are seeing elevated rates of suicide amongst construction workers at home or when they're away from job sites or while they're laid off, that's still something for us to be paying attention to. That's still encouraging us or kind of calling upon us to look at why that is happening. What is going on here? Why are our rates elevated? So that we can take action and reverse those trends. Next slide, please. Okay. So why, as I just mentioned, why? What are we looking at here? Before I go into some of these work-related considerations around some of these higher incidence rates, I want to definitely take a moment to kind of just recognize and acknowledge the protective factors of this work, the strengths of this work. I know I am totally preaching to the choir here. I don't need to tell anybody on this call, but what you all do or have done, if you have or do work in the field, is incredible. I was recently giving a presentation, or part of a presentation in St. Louis. Hi to any of those folks, that ADC, if you are on this call. And somebody in the audience, one of the members, spoke to the fact that they are, when they talked about what they do to cope, talked about they like to go to museums, they like to go to art museums, and then kind of connected that to themselves as an artist. And you're artists. This is skilled labor. I saw, I guess some meme or graphic lately that was something to the effect of what it's like to live with a construction worker. You're driving around. I built that. I built that. I helped build that. I built that. And so there's a true pride and sense of industriousness and accomplishment and achievement, and legitimately so. It should be there. There are absolutely protective factors about this work and role. But as Lily talked about earlier, there are also challenges of this work. This is hard work. This kind of work is not for the faint of heart. We know that that is connected to or correlated with some of the challenges that we see. So, or some of the rates that we see. So what are they? What are some of these challenges? For one, layoffs, seasonal or inconsistent work, demanding and competitive schedules, being away from if you're working on job sites or projects away from your families or your support networks, you're kind of isolated in that sense. You're away from, especially if you are kind of, this is a later bullet point here, but the fact that it's a male-dominated industry means that there are the norms that go along with that. They lend themselves to things like stigma and shame and treatment, professional or formal treatment avoidance, and in favor of informal sources of treatment. So leaning on family, friends, religion, church, things like that. And those are absolutely great and amazing. And I could not recommend those things more strongly. But obviously, if there is a severe mental health condition that's significantly impacting your ability to function, we want to make sure that there aren't barriers in place, such as stigma or shame about seeking more formalized treatment. Work-related injuries, chronic pain. We know that having a high risk for pain means being at higher risk for receiving an addictive opioid prescription. We also know that simply just by identifying yourself as a construction worker to your medical doctor significantly increases the likelihood that you will receive an opioid prescription, even if you are presenting with the same symptoms as another individual working in another industry. It's rigorous work. It's exhausting work. There's physical exhaustion. Issues around paid leave, presenteeism. In our industry, we see it all the time. I literally have spoken to a member before who said to me, I don't want to be alive anymore, but I need to go to work tomorrow. Like, that is a real, I don't even, my heart like bleeds even repeating that back for the kind of struggle that our folks face. These are, I know I'm preaching to the choir here, but folks who are leaders and providers and breadwinners, and they're taking care of their families in that sense of, I got to show up, I got to be there, while you're pushing through some other personal challenges, counterintuitively can worsen some of these mental health struggles. I commented on industry norms, being a male-dominated industry. Pre-existing factors. Construction workers have a higher risk or may have a higher risk for having experienced adverse childhood events or early childhood trauma. Just some other cultural considerations, the fact that it's really a work hard, play hard kind of culture. I have heard before that many years ago, certainly not in any of our recent memories, but that wages for construction workers were subsidized by alcohol, that they were given instead of money, they were given alcohol. I'm certainly not saying that has a causational relationship with elevated alcohol use disorder rates in the industry, but these are cultural considerations when we're looking at why do we see some of the things that we see. This is a huge one when we think about work-related considerations, a lack of support. The fact that in this industry, we have historically or traditionally been in a place where we don't want to talk about it. We don't want to deal with it. Excuse my language. Actually, since this was being recorded, I will not use the typical colorful language I might otherwise use right now, but leave that crap at home. Don't bring that here. Kind of just not dealing with it. And when there is that lack of support, whether it's a perceived lack of support or a real lack of support, that worsens the presentation of the types of challenges that we see. Next slide. Okay, so we have a social and an ethical imperative to respond, all of us, at every level, all of the stakeholders, the workers, the union leaders, the contractors, the project owners. I mean, everyone who, is involved with the interests of people, BAC members, of construction workers, has to be in just living ethically, frankly, respond to these calls to action that we are seeing. And frankly, I think being a part of a union just lends itself so naturally to why we respond. This is what we do. This is so consistent with our values to begin with. This is, we can't talk about things like a good quality of life, benefits, healthcare, good wages, having a roof over your head, quality of life. All of these things are consistent with having a good quality of life without addressing things like mental health. So with that said, this is kind of the wraparound approach or response that it's consistent with or mirrors a public health model. We have to address it from a prevention standpoint. How do we stop this from happening? We have to address it from an intervention standpoint. What do we do when it is happening? And then we have to address it from a postvention standpoint. What do we do after a crisis or tragedy has occurred? Next slide, please. So first, kind of talking in a little bit more depth about the prevention piece. This is really kind of like what is called, I know this is a little bit jargony, but like the upstream piece to this. This is what can we do differently to substantially reduce the incident rates to begin with. And one of the big things is cultural change. We need to be willing to get real and have the hard conversations around how we historically think about these types of challenges and issues. In my kind of exposure or experience, rather, it happens all the time. You don't even realize that we're using stigmatized language or attitudes or holding on to stigmatized beliefs about these types of challenges. Things like, if only they were stronger or tougher, had more will, they wouldn't be dealing with this crap. This wouldn't be a problem. Anybody that does struggle with these types of issues is weak, doesn't belong here. We need to invest in and be willing to embrace the concept of cultures of care. I know that's a really kind of like, coming from a therapist, coming from a mental health professional, a really kind of like cliche title or language, the concept of cultures of care. But what I'm really saying is, we got to treat people like they're humans. I mean, we have to bring some humanity into the conversation. It would be unbelievable if we could treat people like computers, like we just kind of program them, or algorithms. We just say, feel better, do better, and then they actually feel better and do better. But that is not how humans function. That's not how humans are. We are deeply complex and layered and multidimensional individuals that, for the overwhelming majority of us, it's not as simple as just, if you care about your family, you won't act this way, or you won't have those thoughts, you won't have those feelings, or if you cared about your job, or if you cared about, yourself. It's just far more complex than that. And we have to be willing to consider what it would look like to have a more humane and compassionate approach to these types of challenges as a part of a greater mission of cultural change, both on the member side and the leader side. It's everywhere. It's for everyone. Collective and community participation, to that point. This is all hands on deck. This really requires everyone. In order to kind of change a culture, there can't just be the one person, in the corner. I often think of myself as that person, but like preaching, like, let's care, let's do better, let's have more compassion. Everybody needs to be invested and involved for there to be real and true progress and trend reversal. So that includes programs and policies, and knowing what the best practices are around mental health and well-being at work, both as leaders and what it looks like to be a worker when you see somebody being bullied or harassed or hazed, or fighting or intimidation happening, on the work site. What is your role going to be in that moment, in that situation? Those policies and practices can be written, they can be unwritten, frankly, ideally both. And then what informs that is more training, more literacy around these conversations just like the ones that we are having today. The very fact that we are having this webinar, and I give BAC leadership so much credit, Lily and Dave, so much credit for having me on, being willing to talk about mental health awareness. I think the BAC in all the building trades, this is not to, I love all my counterparts at all the building trades. This is obviously just an industry-wide effort. But I think the leadership at the BAC has been just nothing but supportive and willing to push these agendas ahead and prioritize this conversation. So the very fact that we're having this conversation tonight is awesome. It's a step in the right direction. Okay, next slide. And then there's the intervention piece. So obviously, even, we can do all the prevention imaginable, both off the field, on the field, and we're still going to see people having crises and acute personal challenges. And so the intervention piece, as I earlier mentioned, is what do we do when that happens? For one, this is where our helpline absolutely kind of shines. We are a resource for somebody having a challenge, having a crisis. Please, if you are a member, use it, call us. If you are a leader, refer members to it, or call us yourselves. Believe it or not, obviously, leaders have challenges too. They're humans too, just like myself. I'm a mental health professional and I struggle all the time. And I say that with pride and vulnerability because I think it sets the tone and it's a model for where I think we can go. We all struggle, we all feel, none of us, not a single one of us goes through life in a totally just linear, okay, all the time place. That's just not reality. And then, of course, in addition to MAP, because as I mentioned earlier, we are not 24/7 available as much as I would like to be, as much as I would try to be. When you have a crisis, we need to know the additional resources as well. MAP is, I'm going to talk a little bit about this, talk a little bit more about this later in my presentation, highly concierge, in-house, knows the construction industry, knows the types of challenges that our membership faces. We are absolutely a part of the BAC family, and we will do everything we possibly can to get you the help and care and support that you need. And that's not necessarily something that 988 can offer. As amazing as 988 is, as 24/7 available as 988 is, it's not concierge in the way that MAP is. So MAP has its strengths, other resources have its strengths. All these puzzle pieces play a part in creating and shaping the greater landscape of helping people who are struggling. So, and then this last piece in terms of intervention is the actual willingness to do something, to say something. It's probably kind of counterintuitive to everything you've ever thought about what you do when somebody seems to be struggling. I hear it all the time. It's uncomfortable. It's uncomfortable to approach somebody who appears to be struggling. Or if you yourself are struggling, it's uncomfortable to reach out for help. We say this all the time. We know that when you reach out to MAP or some other resource, it's like picking up the 500-pound phone, which I think is part of the value of our department. Because if we, a lot of our members, a lot of people in the workforce, first of all, might not even necessarily know where to go. Okay, they finally kind of like conceded that they might need help. So now what? Who do I call? Where do I go? And then you make that first call to that first therapist. That person doesn't answer. It happens all the time. You call the second person, you leave a voicemail, they don't call you back. The next number you call is a dead line. It doesn't go anywhere. This new person doesn't take insurance, et cetera, et cetera. You're like, screw this, I'm done. I'm not trying this again. And ultimately, connection to help is not secured, which is exactly what we don't want to happen. So we, on our end, absorb all of those frustrations. We will only connect to care that is accessible, that is affordable, that is in network with your insurance, so forth and so on. But sorry, kind of deviated from my point here about action and implementation. It's the willingness to actually do something when the moment calls for it. And then next slide. And then this postvention piece. So that's probably a word most folks are not familiar with. Postvention is the organized response following a crisis, appropriate and helpful acts that come after a dire event. So this really kind of feeds back into the prevention piece because crises specifically I'm talking about here, and postvention is also often talked about in the context of a suicide. If a suicide happens, a person dies by suicide, suicidality or a death by suicide is actually a social contagion, meaning that simply just by the act of somebody dying by suicide alone significantly increases the likelihood that other people in that individual's orbit or community, so like your coworkers, the people that are working on a job with you, for instance, will also die by suicide. That's what's meant by a social contagion. So understanding the importance that it's just as important to act appropriately after a crisis happens or after a tragedy happens as it is to act preventatively so that it doesn't happen is a really important piece of this whole I guess, response or strategic response to some of these issues. That might look like, so for leaders, that might look like bringing somebody in, somebody like myself, I've done this before, to a job site after a tragedy happens, after a crisis happens, to do critical incident stress debriefing, crisis stabilization, mental health first aid. And frankly, even if not a single person, so if I come out to a job site after a crisis, after a tragedy, and not a single person talks to me or says that they need support, the very act of my being there, that demonstration of care and concern by leadership in and of itself is an agent of healing. In and of itself is a meaningful effort or initiative that leadership can take to show workers that we care. And that's a part of that prevention piece. That's a part of that culture of care that I was talking about earlier. And then for members, it's to be willing to talk about it. It's to help destigmatize it. It's maybe being willing to start a meal train or talk to a local leader about the possibility of doing a fundraiser of some kind. It's just what it looks like, what it means in action to show up in a more humane way after a crisis and tragedy happens versus, all right, back to work, let's go, without addressing it. Okay, next piece. Oh, really quickly, I also want to say about this too. You can go. This is fine to say on this slide, but another part to that after a death, an overdose death, and this absolutely kind of is a part of culture of care, a part of destigmatization, but is for leaders the consideration of like a recovery-friendly workplace, being supportive of workers that are living with substance use disorders or substance misuse, substance use challenges, rather than seeing it as a character flaw or a moral shortcoming or failure. It's recognizing that these are real diseases. If mental health is health, I talk about this, I believe in this slide, mental illness is also illness. And it's not just a matter of will or do better. So maybe that can be like a different webinar, a different day, just simply the topic alone of recovery-friendly workplaces. So this is majorly oversimplified, but things I would love for folks to kind of keep in mind. Generally, I'm encouraging folks to, this is certainly not comprehensive. I would certainly not call this any sort of formal training, what I'm about to talk about in this particular way, but to familiarize yourself with what a warning sign is, a warning sign of a mental health crisis, a warning sign of suicide. This list here specifically is looking at suicide, but there are more broadly, we're looking for drastic or extreme behavioral changes in appearance and affect and mood. With suicide, you're looking for, is somebody talking about wanting to die or wanting to kill themselves? Are they looking for a way to kill themselves, as far as you know? Are they talking about being a burden to others? The world doesn't need me anymore. I just make everybody miserable. I'm no good. Increasing the use or drastic changes in the use of substances or alcohol. And as I mentioned, sharp changes in behavior, such as extremely anxious or agitated, especially if that's out of character for that person, behaving recklessly, extreme rage, talking about seeking revenge, extreme mood swings, withdrawing, isolating. I've heard people talk about, you know, they didn't show up for work, they came back the next day, then I never saw them again. Turns out they died by suicide, sort of thing. If that's an out of character trait for somebody, you know somebody to be really social and engaged, and all of a sudden they're kind of just disappearing without explanation, that's a warning sign. And then the question is, what do we do with these warning signs? As I mentioned on a previous slide, the importance of action and implementation. So this is the moment where I'm going to not just ask you to, but encourage you to pull somebody aside, whether, you know, this is your brother or sister on the work site, you are a leader in some sort of leadership role, obviously still your brother and sister or sister, but being willing to, in a way, obviously, as I have bullet pointed here, directly, privately, non-judgmentally, you okay? You know, what's going on? You don't seem like yourself. I care. I'm here for you. And then, you know, depending on what that answer is, if somebody's in crisis, you stay with them if it's safe to do so and get help. You contact 911, you contact mobile crisis, you go to the emergency room. It's really important to understand. This kind of bleeds into the next point a little bit, the importance of dispelling myths. And this is why trainings like, or conversations like the one we're having are so important. You know, if you ask somebody about suicide, are you thinking about killing yourself? You know, that for a lot of people, especially folks that aren't even comfortable with using the word suicide or killing oneself, which is frankly, probably many of us on this call, we might think that if we ask that to somebody, we might offend them, or we might put that idea in their head. And statistically, paradoxically, the opposite is true. That if you are coming to somebody in that culture of care way, that compassionate way, and they understand that you are approaching them from a genuine place because you really care, you're really concerned about them, that the opposite happens. That it is the very act of you asking, are you okay, is a protective factor against suicide, because it's a moment of relief. Somebody does care. I'm not alone. Help is available. I'm not a burden. The message that it sends, the very act of just asking, the message that it sends in that moment, and then obviously what comes next is important too, but the very willingness to ask in and of itself is a major, major moment of truth for people, and really, really a healing opportunity. So this next point, just about being willing to challenge potentially stigmatized beliefs and myths about mental health challenges, about substance use disorders, understanding, you know, this is just common language I hear all the time, that mental health conditions and seeking help for mental health conditions are not weaknesses or character flaws. Frankly, arguably, you know, there's a saying, it goes something to the effect of, the gentler you are, the stronger you become. You know, I know we know a lot of tough guys, a lot of tough folks in this industry. I might argue that that isn't really strength, that that's actually the much easier path than the path of having to say, I'm sad, this hurt me, I'm not okay, I'm not doing well, things are really hard for me right now. That to me, if you've ever sat in a room with somebody while they are bawling their eyes out, I can promise you, you don't know what it takes to get, especially a person who has only ever come from a place where they're kind of, their understanding, their personal values, their cultural values, where they come from, how they were raised is, we don't do this, we don't deal with this kind of stuff, we don't have feelings, we're robots kind of thing. To be able to sit there and cry, oh, that is much, 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 much harder than telling somebody to go F themselves. Okay, next slide, please. All right, so I am going to say a lot of things right now. Just as far, I'm going to talk more specifically about MAP, our helpline for members when they call, what they can expect. This is an opportunity for intervention. It's an opportunity for help. It's an opportunity for care, for support, care coordination, meaning connection to treatment. So we do all of the legwork. If you do not, for any number of reasons, have insurance, we will figure out an alternative. We will get you somewhere that has offers pro bono services or low-cost services, or has grants or scholarships or community funding in place that covers the cost of treatment. If you do have insurance, we're finding support resources that are in network with your insurance. If it's not mental health treatment, substance use treatment, it's other resource connections. It's guidance, it's psychoeducation. There are a lot of folks that think that, for instance, major depressive disorder is just staying in your bed and crying all day. That is not, by the way, in the overwhelming majority of cases, what major depressive disorder is. Most people that are living with major depressive disorder, especially in our industry, may not even know that they are living with major depressive disorder. A lot of people that are living with major depressive disorder are very high functioning individuals. That doesn't necessarily mean, though, that they have a good quality of life, that they're well, that they're operating in a really well place. So even just screening for some of that is what we do. Psychoeducation, talking to people about these issues, clinical consultation, problem solving, crisis intervention, case management, simply just being a safe outlet, somebody to listen. If you feel like you have nowhere else in the world to turn, call me. I would love to talk to you. I cannot tell you how much I love talking to our membership. If the BAC will have me, I will be here for the rest of my career, 1000%. All right, I'm being conscious of time. I'm going to breeze through, especially because it's Mental Health Awareness Month. I actually pulled that out my DSM earlier, but my video is off, so I'm not even going to show you, but that's the Diagnostic and Statistical Manual of Mental Disorders. It is massive. It is a massive, massive book. We aren't just talking about happy, sad. Like, we are talking about a lengthy, extensive kind of, I guess, catalog, if you will, of kinds of mental illnesses that people live with and struggle with. The kinds of calls that we get, the kinds of stuff that we see, this is obviously by no means a comprehensive list, but depression, suicidality, bipolar disorder, anxiety, chronic stress, burnout, self-esteem challenges, anger management, trauma, grief, addiction, which can include substances, obviously, alcohol addiction, opioids, cocaine, methamphetamines, inhalants, gambling addictions, gaming addictions, internet addictions, so forth and so on. Life hardships, you all are human, so you know what those things are. We all have them, myself very much included. Domestic violence, involvement with the carceral system, child protective services investigations, those facing homelessness or eviction. Maybe a loved one has received a concerning health diagnosis or the loss of a loved one. If you're not having interpersonal challenges, maybe at work, maybe your kids are being bullied at school or they're bullying at school, or otherwise having behavioral issues. Maybe you're caregiving for an elderly parent. Issues having to do financial hardship, things that are financially prohibitive, home maintenance stuff, repairs, other unexpected bills, relationship struggles, marital challenges, divorce, medical diagnoses, chronic pain. We all know that this is not exactly like an easy time to function in the world. Social unrest, family of origin conflict, issues with having a family, fertility issues, miscarriage, loneliness, isolation, recent failures or losses or rejections in some sort of personal endeavor, non-visible disabilities, victimization and other injustices, parenting challenges, uncertainty with large looming life decisions. If you're feeling overly burdened with personal obligations, or you're just wearing too many hats, we know, oh my gosh, every single person I talk to in this industry wears, I mean, like 10 million hats. You know, if you pair that with wearing a lot of hats and like not necessarily inclined or prone to being active or intentional about self-care, that can be a recipe for disaster. Your own personal social problems, just the cost of living, other things going on with work, just general fear, insecurity, shame, hurt, confusion, feeling out of control, feeling trapped, embarrassed, helpless, guilty, disappointed. Workplace stuff, hazing, bullying, harassment, injuries, direction, offering direction if you need legal help. I mean, that's just I'm out of breath after that, but a very kind of brief intro into the kinds of challenges, quality of life challenges that may or may not be risk factors for mental illness, but are certainly associated with mental health, negatively impacting mental health, even if it's not a diagnosable mental illness. Next slide. I'm trying to be as conscious of time as possible. Sorry, folks, I can really be talkative. And then MAP for leaders. I know we have many leaders on this call. Frankly, really anything related to anything that I've talked about thus far, call me, let's talk about it. I will consult with you. We'll try and come up with solutions. I'll make recommendations, best practices for any given situation if it's MAP related, just from a mental health professional standpoint, using my clinical expertise as it pertains to MAP related issues. I'm a resource for you as well. Let's collaborate. I'm happy to partner with you. I do presentations all the time, content development all the time. I'm happy to advise you on any meaningful way as far as what addressing mental health and wellness looks like in your particular local or ADC. Let's talk about it. I'd love to talk about it with you more. And then, we need you because I'm in my office at headquarters in DC. I'm not out in the field. I would love to be out in the field, but I'm not. I don't have the same kind of access that you all have. So kind of like the actual dissemination or spreading the word, the outreach, the promotion of MAP is incumbent to some degree upon you all, not to give you yet another thing to do, but we want to get the word out. We want to be talking about this. So promoting MAP, talking to people about it, directly and indirectly. And then we recently added to the principal officer portal, which my understanding is a lot of staff, just local ADC staff has access to that portal. We have a whole section on there as well. I recently just posted just specifically resources and information for local leaders as it pertains to Mental Health Awareness Month. I highly recommend checking it out. Next slide. So actually utilizing MAP, interacting with MAP. So I've kind of shared it probably like 5 different times throughout this presentation, but that hotline number, that helpline number, call us. We tried to make it easy and seamless, 1-833-MAP-TALK. And then my direct line is here as well. I recommend taking a picture of this slide if you have your phone available. My direct line, my email address, and then kind of this asynchronous opportunity to get the I guess information or extract from us what we offer. Read our article. I write an article for every journal. We develop flyers, articles all the time, our wallet cards, our hard hat stickers. Get it out there, use it. And then this is like my baby, the MAP Now website. So I have these 2 links here. The QR code here links to MAP Now. MAP Now is basically just this calendar-based campaign where I am trying everything that I possibly can to destigmatize this topic and make it more just normalizing the conversation. So every month, whenever there's a week, a MAP-related kind of national, international campaigns, such as right now, we know Mental Health Awareness Month, I'm posting and publishing content about that, resources. If nothing else, like I said, it normalizes the conversation. But if you are a local leader or ADC leader, I recommend plugging this on your website, direct people to it, because it changes all the time. I'm circulating it all the time, depending on whatever month or season it is. And if you're a member, visit it often. See what's going on, spread the word. All right, next slide. And then I recommend taking a picture of this slide as well. These are additional resources because MAP is great. MAP is huge. I love what I do. I'm super passionate about it, if you cannot tell. But there are other resources out there, and they're amazing, and they complement what we do. What we do is very concierge. It's very personal and in-house, and we're one of the family, if you will. I should also mention, when you call us, we are a confidential and free resource. We're not going to tell anybody that you called. We operate just like any other doctor's office or clinician's office would, unless you give us written permission or consent for us to, because we need to advocate on your behalf. It's completely and totally confidential. With that said, we still do have internal knowledge of the kinds of challenges you face. We understand it. We have the language, we have the background, we have the understanding. But all these other resources are huge and amazing too. 988, the 3-digit number, that's burn it into your brain. That's the 24/7 suicide and crisis lifeline. It works in Canada as well. They have a chat function. A different crisis text line feature is texting. If you text home to 741-741, that's 24/7 counseling via text as well. They're not licensed mental health professionals, but they do have training and literacy in the kinds of conversations that we're talking about. 211 is another 3-digit number I highly recommend everyone familiarizing themselves with. That's going to connect you to, in almost every locale in the US, to essential community resources. So maybe if you're having trouble with bills or food or any number of issues, 211 is a great number to call. SAMHSA also is a national 24/7 national helpline, has a 24/7 national helpline as well. Your locals and health funds are great resources. I am constantly impressed with what I am hearing locals are doing, like in the field, on the ground, running their own 12-step programs, peer support networks, having their own just peer support webinars and groups, Facebook pages, just to talk about these kinds of issues. I mean, it's incredible. So ask somebody at your local what do we got? What do we do? Do we have anything? If they don't already have them in place, I'd be willing to bet they will, you know, shortly forthcoming, because folks are paying attention and taking notice. This NAB2 link here is just filled with resources, especially for leaders, toolbox talks. I mean, just the list goes on and on. Data, all sorts of things. Highly recommend checking that out as well. I really, really like, I especially put this for the Construction Industry Alliance for Suicide Prevention, another great resource for leaders, but they have what I think is huge access to these internet screenings, mental health, substance use screenings. I highly recommend checking that out, doing a screening. And then this is the website for mental health and wellness in Canada as well. All right, next page. Okay, so really last thing, and then I think we actually saved a few minutes for questions. I just want to say, I'm going to turn back on my video here. I just want to challenge everyone or encourage everyone to kind of like make a commitment in honor of or recognition of Mental Health Awareness Month to take something from this conversation today and implement it into your life somehow. If you feel like, especially as we did our check-in earlier in the call, I'm like not really doing so well right now. Maybe that is your sign. Call me, ask somebody else for help. If it's not going to be me, ask somebody. Check on somebody you're concerned about, commit to that, pledge to do that. Commit to learning about a mental health condition that you've always been curious about, but don't really know enough about, or you think you might have kind of stigmatized lens or understanding about what that issue is. Learn about it. Google it, research it. The information is out there. It's huge. It's amazing. It's incredible. But I really just want to encourage everyone to see what they can kind of, in honor of and recognition of Mental Health Awareness Month, how they can commit to maybe just taking one thing away from this conversation and letting it impact, being intentional about letting it, about doing something differently. And that's it from me. So I'm going to pause myself. I know we've got just like a minute left, but sorry I went over. I didn't leave a lot of time for questions.
No problem. That was great information. No. I have it's a question / maybe you could help us. Being on the ACOSH committee for the last 2 years, and now Lily is currently sitting in that position with OSHA. We always talk, the big talk was supervisor foreman training about suicide and health. Is there any PowerPoints out there? Could we work together and maybe create something for our foreman / supervisory training, and then to get disperse it throughout the country to all the training centers? Because
so this is actually,
you did go over some. No, go ahead.
Oh, sorry, what?
No, you did go over some of the things like science, but maybe if we could put some.
Oh, no, that's not, that was definitely not meant to be like, by no means, like comprehensive or like life-changing for you per se, just very, very brief intro. So a couple things on that. First of all, that page with the NAB2 CPWR links and resources, they have put together some like huge and would be more than happy to have like solicited this, offered it, like insisted upon it, doing some like train the trainer opportunities specifically on opioid overdose. I know they recently released one on, I don't think it was mental health per se, more broadly. It was very narrowed. I can't remember what the training was, but there are definitely links to trainings from there. On the MAP website as well, the MAP Now, sorry, this is not MAP Now. This is on the portal, the principal officers portal, and I can get it to Elizabeth to put up on the IMI portal as well. There is a link to specifically a training from one of the universities. I want to say maybe University of Chicago, but maybe I'm just thinking Chicago because I'm on the call with Dave and Lily. But a training specifically on suicide in the construction industry. I myself am wanting to do, and I've been in many talks with Jerry about this, but an opportunity to get certified in the delivery of, so I'm certified in mental health first aid, but becoming a mental health first aid instructor so that I myself, like in-house, can provide, like as a certifying body, so that you can actually leaders can actually get a certification, a mental health first aid certification. That's kind of forthcoming. But absolutely, right now, today, informal trainings, like I myself can't just say, Alex Jacobi, now pronounce you certified. Like there has to be a certified body. But I will work with anybody who is willing to work with me on doing any training on any kind of topic that is relevant to my issue. I come up with content all the time. And then there's plenty of stuff out there. So I definitely recommend checking out the principal officer section of the website, that portal, and then on IMI as well, the contractor. And I'm not sure if there's for IMTEF, we can talk about that, Dave. But yeah, there's definitely plenty of opportunities for trainings, and I try to link to those trainings that exist, especially from like certifying bodies, every opportunity I can. We also are talking about the possibility of doing something like that, offering something like that at the upcoming local leaders conference, an opportunity to get certified in mental health first aid at work. So big conversation. There's definitely stuff that's out there, and definitely will be more forthcoming.
Thank you, Alex. And I know that we're a little past time, but we do have one question. And thank you everyone for staying on. This is a great topic and very important one. So thank you again. The question is, what are some things that are going on for Mental Health Awareness Month?
Yeah, so this call, right? Like this conversation, the willingness to have this conversation. So MAP Now, which I talked about earlier in this call, is really kind of my kind of centric place that people can, I guess, the landing, that's not the word I want to use. There's a word that I'm thinking of that it's not coming to mind, and I'm sure it'll come to mind as soon as we get off this call, because that's just guaranteed to happen. But a place that can connect you, provide psychoeducation, spread awareness, destigmatization, connect you to further resources. I did a webinar with IMI ahead of, just a few days ahead of Mental Health Awareness Month. And it's really just trying to spread the word and bring as many people into the conversation as possible. That in and of itself, I know it feels like it's a passive step, but when even just 5 years ago, 10 years ago, a conversation like this, a training like this, a webinar like this, I mean, maybe we didn't even know about webinars pre-COVID, really, was that even a term? It wasn't happening. So this is not a passive moment. This is the work. Us being willing to get real, have the hard conversations, talk about it frankly, in and of itself is the work. I highly recommend visiting the MAP Now page as well, though, because that's gonna further connect you to additional resources. But that's just at the international level. And especially as the months go on, we have Suicide Prevention Month coming up in September. I would love to work with locals and strategize things that other folks can do in the field, on the ground, to actually, there are unique opportunities that those folks have that unfortunately I don't necessarily have to advertise, to promote, to have the conversation. I really recommend visiting that website with the screenings. I implore every single person, this is an action that I take more seriously maybe than anything else. Get off this call, take a mental health substance use screening.
Thank you. And I did share those resources that Alex had in her presentation. They're in the chat. I hope that you're able to see them. If you don't see them or can't link to them, please email me. I can get you those links. I can send you those links via email. Thank you again, Alex. Thank you, Dave, for being on today and, having this discussion that needs to be had. And like you said, we got to work on destigmatizing the word, right? And being able to help our members. That's our number one goal. Again, thank you for your time. Thank you for your presentation. I really, really do appreciate it. Any last words from Dave?
Yeah, there was it wasn't a comment or it wasn't a question. It was keep the two bricklayers in Cleveland. There was a scaffold accident. 2 of our members
Yes.
went down with the mass climber. Just keep them in their prayers. I'm not sure how they're doing, but one was pretty bad. The other one was hurt, good. But I believe one was released. The apprentice was released. Heard the journey worker's still in the hospital. So keep them in your prayers.
Will do.
And that's all I
Thanks,
have. Thank you, Alex.
Thank you,
Yeah,
Alex. Thank you, Dave.
Appreciate you all. Take care, everyone. Bye.